this morning. Today we have with us our team from Vizient. We're going to go back over the CDB. They were here in May and gave us a lot of good information. But as we continue to mature, as we continue to learn, we want to continue to reiterate that information further. So new folks, I think that are working to learn back in May. So we have our experts here. We have Steve Meuer, who is going to lead the presentation. Steve is going to be the architect building it and has all the expertise that they might ask for. We have Christina Priest, who's our engagement manager. And
we have new titles since I was here in May, so it's operations and quality executive. So just kind of aligns a little bit better with what I do for your things, my CDB, CPFC, and
we work very closely with Christina. We all on a daily basis. So a lot of interaction there in building our and then Tom Stoffel, who's our who's also in that whole I will turn it over to Steve. I'll keep my remarks brief and just look forward to a really nice day of learning and hopefully discussion around how we continue to use these data.
Great. Thank you, Todd. Let me get over here and do this. It's great to be back here in Oklahoma City. So first, Christina, Tom, and I are all from the north. We're from Chicago, just south of Chicago, Michigan, and we want to tell you that yes, it is cold here today. It's actually colder here than I think it is up there this morning. It wasn't yesterday. It was 30 degrees warmer yesterday when we woke up in Oklahoma City, but it is cold here. So this is, I want to make it a little bit more interactive, a little different than what I did in May, particularly knowing that we have two other experts of the clinical database, or at least those individuals that have known and spent time with the clinical database for a number of years, and Jonathan and Rick, who have both been with organizations that have had this clinical database for a number of years. So at any time during my comments and during my presentation, you feel like you want to be able to ask a question, make a comment, engage in dialogue, please do so. And we'll move forward. And that is in particular for Rick and for Jonathan, because I want to be able to make sure that you get the insights that we have from the clinical database as we move along. I want to start with a quick story about East Carolina University Hospital. They were Vidant before, but now they're East Carolina University. Now in 2018, East Carolina decided to move away from what we call Vizient to one of our competitors. Now, if you don't know, Vizient is much more than the clinical database. It has, well, I like to call it 4 different verticals. We belong in the Christina and I belong in the operations and quality vertical that brings you the clinical database, the operational database, consulting along with it. But we also have a lot of work in the supply chain. We're a group purchasing organization. We have a lot of work in pharmacy. We have a lot of work in strategy at Vizient. And so East Carolina at that point in time in 2018 decided to move lock, stock, and barrel everything to our competitor. Now, if you want to know that story, I'd be more than happy to tell you that, but that's over more of a glass of wine in the evening. That was in 2018, and they had just received their quality and accountability study. This is the ranking that we give to our members who are in the clinical database. They were 24th East Carolina University Hospital out of, at that point, about 99 hospitals, 99 academic medical centers. Fast forward to about a year and a half ago, East Carolina University made the decision to come back into the clinical database. After they would say 4 years with the competitor, 4.5 years with the competitor, where they struggled to really get information and data out of that database. They just received their latest quality and accountability study, and they were 84th after 4 or 5.5 years. And I asked them, I sat with them and I talked to them. I said, what do you think is the reason for that decline. They didn't say there has to be something with the data, there has to be something with this. They said, we just have spent 4.5 years trying to get data to help us understand how to improve. And we now know the power of the clinical database, which is that we spend more time actually doing changes, making changes to improve, rather than trying to get the data to help us understand where we need to improve. So they are back on the path of getting back where they need to be, but it's all about figuring out how to be able to drill down far enough to understand where you need to change and then making those changes. That's what this is all about. This improvement journey that we have is all about. And what we're trying to do at Vizient is we're trying to, as the old adage say, we're trying to give you, not give you just your opportunities and walk away. We're not here to just give you reports to tell you where your mortality risk adjusted metric is. We're here to be able to teach you how to take a look at that, ask the questions to understand why you might be different, where the changes need to occur, and drive you to be able to fish. So we want to be able to teach you to fish so that you will eat for a lifetime rather than just giving you a fish. This is said from someone who doesn't fish, but I do spend a lot of time in the clinical database. So that's what we're really trying to do. And then down below, I've just given you your cheat sheets, your what I would say would be your first things that you need to be able to do. In the afternoon session, we're going to go through a lot of visioning about how to be able to go about doing these types of things, the steps that you need to do these. I also know that you've already kind of really checked off box or the number first thing, which is consider using the Q&A as your executive dashboard, the Quality and Accountability Study, which is a balanced scorecard. So that's good news. So for those of you who are fairly new to the clinical database, let me just tell you that we now have close to 1,100 hospitals in the database, sending us all of their inpatients and all of what we call hospital-based outpatients, which are ED, observation, ambulatory surgery patients, on a monthly basis. This data is going to be about a month in arrears, so that for February patients, you'll be able to start to see those in April or so. And it is transparent by all 1,100 hospitals, which means that you're able to go in and develop your own custom compare groups. You're able to go in and choose one hospital if you want to compare yourself to them. And this is available not only for the adults, but also for all the patients in this hospital. There are 1.5 million pediatric inpatients and over 17 million hospital-based pediatric outpatients that we have in a year. Now, you're not going to see pediatric data in my presentation. That pediatric information has just kind of populated. We're going to be putting together a separate a report that Christina is going to be able to bring back and give you a sense of where the pediatric hospital looks compared to all other organizations. Here's the data that we get on the top left-hand side, and then all the stuff that we do to it when it comes over to us at Vizient, including adding and flagging patients for 6 sets of complications. So everything from the Agency for Healthcare Research and Quality patient safety indicators. We also have the agency's pediatric indicators. We've got CDC's maternal morbidity indicators. We also have the Nissen infection control data that we go out and get from the CDC on a quarterly basis, so that you're able to go in and say, how do I look on any one of those complications versus any of my peers, and be able to drill down into those. We have 2 sets of risk adjustments, 2 risk adjustments for each patient in the database. One is the very specific risk adjustment that we give to every patient that comes in the format of expected values for length of stay, for mortality, and for cost. So even a normal newborn will get an expected value for mortality, although that expected value has maybe 20 different numbers and it's 0.000. Every single patient will get an expected value for mortality, length of stay, and cost. That is based on models that we build that are very specific to that clinical condition. So we're only taking sepsis patients, and we're only comparing them and modeling them against other sepsis patients. And I'll show you that here in just a little bit more. The nationally known, most nationally known risk adjustment out there in healthcare is by 3M. It's in the APRDRG grouper, and it's called risk of mortality and severity of illness. So some national agencies use it, ROM and SOI. It comes in 4 categories, puts patients into either minor, moderate, major, or extreme. And since ours is much more specific because that ROM and SOI compares every patient to all other patients in your hospital and in the US, then we have built what we call the Vizient acuity scale, so that you can go in and you can of what the ROM and SOI would be. Our Vizient acuity scale comes in 4 categories: well below, below, above, and well above. So you have the ability to toggle back and forth to look at risk adjustment in a number of different ways. Also flagging patients for readmissions. And we also have cost in the database, direct cost, total cost. This comes from the CMS worksheet that we go out on your behalf to get. It's the worksheet that your finance team develops and submits to CMS mandatorily on a year-to-year basis. That will be what we call ratio of cost to charges. And I'm going to show you a little bit of that as well. It's not just a database to help you improve, which is all the stuff on the left-hand side. We've also got other stuff that help our quality departments satisfy regulations from CMS, from Joint Commission. So you're using us as your intermediary for Joint Commissions and CMS's core measures. We have a provider insight tool, which allows you to satisfy Joint Commission's OPPE requirements. We've got CMS calculators. We literally go out and get your CMS stars information and your value-based purchasing information, bring that back, and you can play around with changing those to see how to improve. And then you're able to download the data back into a data warehouse here at Oklahoma, because we want our metrics on your dashboards. And then also, we are not just going to give you, as I mentioned, this database and leave. We've got Christina, we've got Tom to help you drive improvement here. We're going to give you everything in the black over on the left-hand side. We have additional items that you really want to be able to pay, maybe think about. We have collaboratives that Rick knows very well, that are about 25 different individual things that you can improve on, and hundreds of hospitals are working on those, consulting, and then we also have these networks. Those are all additional costs. Now, this is the first time of many I'm going to say what's in the middle, and that's your responsibility. Your responsibility is going to be to have some sort of leadership focus, leadership attention towards improvement. Then you have to get to what I'm calling insights, and you'll see what I mean by that here in a few slides. I've seen organizations that have that leadership focus and the insights get that third bullet, which is the engaged clinicians. That gets you more than halfway there to improvement. So that's really what your focus is, and we're going to help you drive that. And then the couple of last slides before we get to the real fun part, and that is we do have tons of webinars that you can avail yourself of in our clinical database, of training of other organizations that have improved. And then we also have what I think is the best conference that exists in healthcare right now. I believe some of you did go to this conference in, yes, and is it not the best conference? Okay, good. It was very good. It was very good. We got a very good, but it is the best because of first of all, the content. There are 30-minute presentations that there are 60 of those that come from about 500 abstracts that we get in February. And as I'm inclined to say, the happy hours are also incredible, but it's not because of the wine. I'm a wino. I love wine as much as I love data. It's the networking. It's seeing people get to know people across the community, the improvement community that we call. And I know that Christina's already brought Intermountain folks, not here, but by video here, as well as Memorial Hermann and a couple of others. Those are relationships that then form, then that you see them at these at this annual meeting. So I would really encourage you to think about going next year. All right, we want our metrics on your dashboards. We follow I follow at least the old Kaplan and Norton from Harvard, their balanced scorecard, where the executives and you all as leaders of service lines, you need to be able to look at a balanced approach to your practice, which includes metrics in operations, quality, safety, finance, and then you can also see satisfaction. And so we can provide in the clinical database most of those information. And if you don't have these already built, the good news is that we have a pre-built executive dashboard balanced scorecard for you. We call it the Quality and Accountability Study. It's also a ranking that you get on a year-to-year basis at that annual meeting, where you get to see your overall rank versus other academic medical centers. Edmond gets to see their rank against other community hospitals. Children's hospitals gets to see their rank against other children's hospitals, and it comes in a balanced way. It also comes very closely aligned to the CMS STARS program. And we did that on purpose. We built it to mirror as much as possible the CMS STARS program, because we don't want you to be beholden on that CMS STARS program, because when you get that in February, it's already about 1.5 to 2 years old. And it's very difficult to go back and grab that data and to understand exactly what we need to do to improve. So what we have seen over and over again, and Jonathan helped me understand this even more yesterday, is that as you improve in the quality and accountability study, you're going to improve in the CMS STARS program. And we've seen this from organizations over and over again, and you'll see examples of that as we move along here. So we want you to be able to not only get this on a year-to-year basis, you're going to get it in calculators, the quality and accountability study, on a quarterly basis, but many organizations are recreating as much as this as possible on a monthly basis to be able to use as their dashboards. They're creating it on a service line basis to be able to use as their dashboards on a month-to-month basis to drive improvement. Also, with the quality and accountability study, as I mentioned with you and also Edmond, we're not going to compare Edmond to you all here at OU Medical Center. You can fall into one of these cohorts. All 1,100 hospitals fall into these cohorts. If you have enough volume in oncology, enough in pediatrics, then you're going to get a separate pediatric score and a separate oncology score. One word about pediatrics. I would say that right now we have about 50 or 60 hospitals that are separated out as children's hospitals in the database. All the rest of those pediatric facilities come in with their adult organization. So for example, Vanderbilt has their submission into the CDB, but Monroe Carroll Children's is part of that submission of Vanderbilt. In the database, it's extremely easy. Just hit a radio button that says, I want to see only pediatric patients. When you do that at Vanderbilt, you're going to get Monroe Carroll's patients, but you're not going to see Monroe Carroll. You'll see it as Vanderbilt. So it's the decision of the organization whether or not to bring those patients in or to separate them out. You've made, I think, the better decision to separate them out. And we're still working with some of our other organizations like Vanderbilt to say, you know what, you might want to think about, since Monroe Carroll is a separate facility, to separate those out. But know that if you're seeing Michigan, you're seeing Michigan Children's in the database as well, if you just push the button that says pediatrics only. Okay, that was the context. Now we start to get into the real fun stuff when we're taking a look at this. Now, Don Berwick, for those of you who don't know, he's the quintessential quality guru of our time, has been knighted by the Queen of England for the work that he did in the NHS, has told us since the 1980s that the biggest issue that he sees in the American healthcare system is our inability to improve. And even recently, in February of 2020, believes that we've lost even more of a focus. Now, I was talking to the chief quality officer at Memorial Hermann, who said that she saw Don Berwick at this February conference where he said this. She went up to him and thanked him for all the work that he's done over the last 30, 40 years in this field. And he said, you know, I wish we could just blow this up, blow the entire system up because of this idea of loss of focus on quality. And if you don't believe him in what he's saying, you just look at our database, which I've just told you people improve in our database. But on average in our database, if we go back to 2019, we have not seen improvements of all of our hospitals in observed mortality, in observed length of stay, in observed cost, in observed readmissions, and observed complications. On average, there's been no improvement, straight lines across the board. We're just not very good in the American healthcare system at getting improvement done. Now, that doesn't mean that hospitals aren't improving. There are plenty of hospitals that are, but then there are plenty of hospitals that are not. Why aren't we? What's going on here? I go back to another quality guru. His name's Avitas Donabedian, late of University of Michigan. Had the job that I continue to search for, which is he got paid to think and write his thoughts down. Was credited with the founding of Quality in Healthcare. Wrote a 3-volume book called Quality in Healthcare that gives us a lot of information on how to improve, including the structure process outcome model, which says if you want the right outcomes, you need the right processes. And in order to have the right processes, you need the right structure. But it starts with structure. And what we've seen, or what I've seen in my 16 years now at Vizient and doing this for hundreds and hundreds and hundreds of hospitals, are these structural and process challenges. What we see, I see more often than not, is I go to organizations and they've got decentralized improvement efforts. What do I mean by that? The group that is tasked with help to drive improvements in length of stay is different from the group that's tasked with trying to improve risk-adjusted mortality, which is different than the group that's tasked with helping to support improvements in patient satisfaction. And they all report to different folks. I was at University of Minnesota Fairview, welcoming Fairview hospitals into the database. I was talking to 7 different people in a group, each of which had some aspect of improvement in their title, in their role. 6 of the 7 reported up to different folks. And after 45 minutes, one of them said to me, you know, we all like each other. We just don't know where our job ends and their job begins. So I said one of the biggest structural opportunities that we have in the American healthcare system is to bring all that together. And I'll tell you a story on an organization who did that here in just a few slides. Less leadership presence driving improvement efforts. That's where I think Don Berwick focuses his efforts and his comments when he's talking about this, is that he's seeing less and less leadership attention. When I go now and present 10 years ago when I presented, I almost always saw the CEO and the COO in the audience. Now I don't see him as much. Now they're here today for OU, but I just don't see him as much as I do because they're just not as much focus in driving improvement. And then the process challenges. We've been conditioned to be able to say that if we give the clinicians the data, if we give you the dashboard, you're going to be able to get improvement done. That has not shown to be true. Because what happens is you get that number, and if there's a red dot, as you'll see in a little bit, human nature takes over. And we start looking at and saying that it's got to be the data. So we work all of our time on disproving the data rather than actual making changes. That takes us to another equation that Avitas Donabedian has, which is that there's only 2 things you need for an improvement. You need data, and you need that data to motivate a change. And where we see more organizations right now is here. They take data, they put it through an analytic tool, they build a dashboard or a scorecard, and then what do they do with that dashboard and scorecard? Directly hand it off to the leaders of the organization and say, improve. And what we find out is that human nature takes over and we attack the data. We have to know that those dashboards and scorecards, that quality and accountability study that you may have seen, you may have heard about, that's information. That tells you that you're different. It doesn't tell you why you're different. And when we attack the data, it looks a lot like this, where Shannon Sims, who works with us at Vizient, has taken the Kubler-Ross stages of grief, transformed those to the stages of quality measurement. And we go through all of these stages when we look at those dashboards and scorecards. Our goal at Vizient, and the goal of the CDB, and the goal of you all, is to get beyond that, to get to acceptance. Okay, maybe we can do better. One of the best things that I liked when I was talking to the East Carolina folks is that they had already taken the data and they had 4 or 5 interventions that they were already working through to get themselves back from 84 to 24. We need to rebalance the equation. We need to get to insights. We need to build the dashboards and scorecards because that's a necessary step in improvement. But then we also need to be able to drill further down to understand why we're different. And those insights come in two flavors. This is all going to be newer from the May stuff that I've talked about. Rationale, which are things that we might not be able to control, and then factors, things that we can control. Let's talk a little bit about rationale first. Social determinants of health are rationale. Your patients walk in with those social determinants of health. You don't have that huge amount of ability to control those or to change those. We don't get that social determinant of health information as much as we would like. What we use for social determinants of health right now is payer status. Whether you are Medicaid, self-pay, indigent, or county, we can lump those together and really get an understanding of a little bit of your social determinants of health. And so to get a better understanding of social determinants of health, in the last year, we've gone out and purchased national data sets by zip code, and we've built what we call our Vizient Vulnerability Index. Now, this is not yours. Yours will be coming in January when we redo this whole thing, but the data sets look at everything from the economic domain all the way down to the transportation domain. So we're looking at homelessness, we're looking at clean air, we're looking at food deserts, we're looking at all of those things by zip code, putting those together, and then creating for a hospital based on the patients, because we get the patient's zip code, we're creating a VVI. The more orange you're going to be, the more vulnerable your patients are. The more blue, the less vulnerable you're going to be. Now, a couple of things about this. This is a great step, at least I think it's a great step forward in helping us understand social determinants of health of our patients. And it's been very helpful for many organizations who've already seen theirs. But remember, it's not by patient, it's by zip code. So for example, Boston Medical Center, which is in the middle of Boston and in the middle of very affluent neighborhoods, sees the poorest and the most vulnerable patients in those affluent neighborhoods. So their VVI actually looks more blue than it should. So just keep those in mind. But also keep in mind why this is important. Remember, this is insights. These are rationale. It's important because when you take a look at our top hospitals 2 years ago, not in 2022, but in 2021, if you look at our top hospitals over on the left-hand side, academic medical centers, you can see they're precipitously more blue than those on the right-hand side. Now, it's not 100% correlated. You'll see Methodist Houston, you'll see HUP, you'll see Rush with some vulnerable patients and still performing very well. And on the right-hand side, where it's almost predominantly red, you'll see H and J, where there are less vulnerable patients and they're not performing as well. Little secret, H and J actually are part of the same system. And there is very little leadership attention and focus on the quality and accountability study or on improvement in H and J. So it does matter. Performance or social determinants of health matter. In particular, I will tell you that it matters because these patients are much more challenging to be able to get out of the inpatient side to post-acute care. We were just down in Miami at Jackson Memorial, who's in the database. And if you take a look at their performance, which you can because the database is transparent, you'll note that they have very, very high length of stay for their patients. And that's because when we were down there, we were seeing that they were acting as not only the inpatient, but also the SNF, the hospice. Patients were staying there 100 days, 120 days. And so that does affect, absolutely affects performance. But the real value of the database of the CDB is to get you to factors. Remember, rationale and factors. Factors are those things that you can control, those things that you can change. So when we take a look again at the oncology service line summary for OU Health, and we're looking at a lot of different things in a very simple dashboard that we've developed, and we highlighted mortality index. Now, mortality index is the O to E ratio, the observed to expected ratio. This is the risk-adjusted value. Anything above 1 is going to be worse than expected. Anything below 1 is going to be better than expected. But Rick yesterday reminded me of something, and that is for mortality over time, we actually starting to do better and better. Now, I mentioned that we haven't done better in observed mortality. We're doing better in expected mortality. So the O to E ratio actually shifts down over time. And so the average for academic medical centers, as you can see right there, is 0.9. So even though above 1 is worse than expected, even if you were at 0.95, you would still be worse than the average academic medical center. 1.37, where you are, is above 1, and it's also well above that 0.9. So this tells you that you're different. It doesn't tell you why, it just tells you that you're different. And again, I would hesitate to say you shouldn't be handing this directly off to the oncology leadership. You should be drilling into it first to understand why. There are 3 aspects that I found that help you determine why you're different: data quality, throughput, and harm. Those are the 3. We're conditioned when we see the 1.37 to think harm, but there are 2 other aspects to really drill down and understand. When you're drilling down, it's like you're an investigator at a crime scene. You're trying to understand why things are happening. So you're asking questions. Well, could it be that we see more transfers from other hospitals and SNFs? Why would that be of interest? Because those patients die 2 to 3 times more often in the hospital than patients not being transferred in. Could it be that we're not using palliative care, end of life services like palliative care and hospice? Could it be our expected values? The expected values are what improve the OD ratio. That's a function of documentation and coding. Remember, in risk-adjusted stats, there's 2 ways to improve it: lower the observed or increase the expected. Increase the expected is more documentation and coding. Could it be length of stay? If our patients are staying in the hospital longer, then there's a greater chance that they have of an untoward event, including death. And then early deaths. Early deaths are those patients that are admitted into the hospital and die within 48 hours after being admitted. And you can see here for OU Medical Center that every one of them, other than early deaths, you are lower than the average of academic medical centers. Let's just take one of them, palliative care, for example. Look at what Hospital University of Pennsylvania has done. Hospital University of Pennsylvania is now 27th of all large hospitals, so hospitals seeing more than 400 oncology cases, 27th out of 266 in mortality ODE ratio. You're at 253rd. 26.5% of their oncology patients are getting a palliative care consult. Palliative care is typically just for patients that are dying, but what they've said is we want every patient that has metastatic cancer to have the option of getting a palliative care consult. And 26% now patients do. They've seen their patient satisfaction improve in the oncology patients, and they've seen observed mortality go down. And there's a study that Rick mentioned yesterday, New England Journal of Medicine, that says over time how palliative care consults can help to reduce the observed mortality. So they will point to that 26.5% as the reason why they've been able to improve an ODE ratio. You're at 6.7% there. The average is 11.7. Notice also the correlations. All of them are low. The highest one is early deaths at 0.42. And so what this means is it's multifactorial. It means that you have to get 3 or 4 factors to be able to work on to improve risk-adjusted mortality for oncology. And you have the 3 or 4 factors right there that I would focus on for that oncology area to be able to say, hey, we know we're not where we need to be at 1.37, but we're going to work on these 4 or 5 things. Now, the first one's interesting because if you take a look at the first one, you remember what I said about factor or rationale. Rationale are things that you can't control. Factors are things that you can. And I've often heard, and I do agree that transfers from other hospitals in particular, well, we can't really control that at our organization. And in fact, there is, when you take a look at OU Medical Center versus all academic medical center, you're 4th in the number of transfers that you're getting from other hospitals. And you can see University of Louisville up there, then Iowa, then University of Southern California, Keck, ahead of you all in terms of the percent of patients. Look at the last column that tells you that those patients in observed mortality die 163% more than your typical patient. Let's say a couple things more about this. I go to Iowa. I've been to Iowa quite a bit to be able to talk to them about improvement, and they are fixated on the fact that they are now the 2nd highest in terms of transfers from other hospitals. And that's the reason why they can't improve in their performance. And I continue to tell them that is a reason, but it is not the reason. So don't fixate on saying this and not getting anything else done. And I'll tell you an organization that's been able to reduce actually their transfers, and that's helped their improvement here in just a second. The other is, look at that third column, the percent of the observed deaths. That's of all patients. About 6%, 5.9% of your patients are dying in OU Medical Center. And you'll note that that is the highest in this list, and it's one of the highest of any in the academic medical centers. Now, I'm not trying to say this again to be able to say something's happening here. Remember, we don't know why that's the case, but the fact is that more patients are dying at OU Medical Center on a year-to-year basis than in almost any other academic medical center. Is it because the other hospitals are getting these patients out to hospice? Is it because the transfers, many of the transfers they're not taking that they know are going to die early? It could be some of those. It's a lot of different things. But the fact is that your observed mortality at OU Medical Center is one of the highest that we see in the database. So we're going to unpack that and take a look at that a little bit more. But let's look at West Virginia University Hospital. Over time, you can see starting in 2019, Q1, they had 31.9% of their patients were transfers from other hospitals. You were at 21.7 at that time. They've gone down to 19%. You've gone to 26.2%. They've made a conscious effort to be able to reduce the number of transfers that they're bringing in from other hospitals, whether that is keeping that patient there and doing telemedicine, whether that is putting services out at some of these hospitals so that they don't have to take this information. Whatever has happened there, it's been a factor in helping them improve in the quality and accountability study from 51st to 45th to 26th. So there are organizations that have made a conscious effort to be able to reduce the number of transfers in from other hospitals and have done well on that. And I can give you more details about what West Virginia University did to be able to do that. The other thing one of the things that I also found interesting is when we take a look at the day of stay where your patients die in the hospital, we typically see what you see on day one and day two, where 26% of your patients are dying early. That's compared to 24% of the other AMCs. So yes, you have some opportunity to look at those early deaths. And the good news for you all is that you're only at about 14.4% of your patients are dying at day 20 plus, where the average for AMCs is about 19%. So in those organizations that have 25% that are dying 20 plus, it's pretty obvious where their opportunity lies. You've got to look at those patients beyond 20. What I boxed here is what I found interesting. Not every one of these graphs that I've seen for every hospital, there is a progressively lower day 3, day 4, and day 5. You're different in that aspect. Your patients are dying more often on day 3, 4, or 5. Now that could mean a lot of different things. It could mean that you're bringing patients in, you are keeping them alive for a couple of days, and then in terms of fetal care, and then realizing that there's deaths that is imminent. It could mean that there are complications occurring look at this. But these are the things that we're going to need and we're going to talk about later today to be able to drill down further on, because that is a very different profile than what we see from every other hospital that I've taken a look at. So even though your early deaths might not be a huge opportunity, I would say that your day 1 through 5 is where your opportunity lies in terms of really understanding how those patients are dying. The organizations that are doing the work that I've just showed you here, that are not only building the dashboards, but drilling into the database to understand where improvement needs to occur, are the ones that are improving. The ones that also have leadership attention are the ones that are improving. You can see our top hospitals last year, they wrote 8,500 reports on average. The bottom hospitals wrote 2,400 reports. There's your correlation with the CMS STARS program. It's not just at the tails, it's at every decile of improvement. You're going to improve in the CMS STARS program. So many organizations have said, wonderful, this is what we need to be able to start using the Q&A as our executive dashboard. But also note that on the right-hand side, the 4 bottom academic medical centers are all new to the clinical database. I didn't bother to put the number of reports that they wrote there. And I will tell you that one organization is a very prestigious organization that has just come in. I was very frustrated when they saw this. But then when we go over, I said, well, you're a 2-star hospital. You know, you know, should have tipped you off at some point in time that your performance may be not as good as everybody else's. But what this also means to me that is if you're new to the database, you haven't had the opportunity to really drill down. It's the East Carolina example again. Now's the chance. Now's the time that you need to be able to drill down into the database and use this. But the key is not to just get this information and noodle over it. It's to find changes, to make changes. And that's what those top hospitals are doing. They're not only drilling into this, but they're making changes. And this one is a really interesting example because of all of the top hospitals that we have in all of our cohorts, 38% of them come from just 4 systems. Those 4 systems up there. So 7 of the 9 Mayo hospitals are top in their cohort, so on and so forth. And you can see they're not only running reports, but what's different about them? Intermountain, for example. Intermountain, when they came in to the database, the CEO of the system said, how are we going to use this? The CNO of the system pointed to the back wall where there were 50 pages tapped up, which happened to be different metrics from different systems, from different people. And she said, we need a single source of truth. So they adopted the quality and accountability study as their single source of truth. What did that mean? Every quarter, their lead improvement, they call him the chief patient experience officer, not the chief quality officer. They did that, by the way, because they brought together all of their improvement efforts. So they were disparate. They were decentralized, and they brought together and centralized all of their improvement efforts in finance, operations, quality, safety, and satisfaction. So instead of calling them the chief quality officer, which would focus on, you know, people would say mortality, complications, maybe readmissions, it's the chief patient experience officer. She would come to that executive team meeting on a quarterly basis and basically say, here's where all of our hospitals are in terms of their percentile rank against their cohort in the quality and accountability study. And Mark, the CEO, made a 89th percentile is where I want all of our hospitals to be. And if you were below the 89th percentile, they would have already drilled down into that hospital's data to be able to say, here are the 4 or 5 different areas that they need to be focused on. And then what they do, the executive team then takes people and say, okay, we need to get people over to that hospital to be able to drive improvement. The other example I have here is Methodist Houston. Methodist Houston, Mark Boom is the CEO of the healthcare system there. He saw me at the annual meeting, grabbed my arm, and he said, I know why that 7th hospital didn't make it to the top of their cohort. It was because of this, this, and this. Mark Boom, the CEO of the system, was telling me that and was frustrated that one of his hospitals didn't make it to the top of the quartile. Give you on the opposite end is an organization where they continue to struggle in the quality and accountability study. And this is an organization of about 7 different hospitals. Their percentile rank overall, if you look at those 7 hospitals, is in the 60th percentile. And one of the things that they have never done is shown this information to their executive team. That we don't want to show this to the executives because it shows us not in a very good light, and we don't want to be able to do that. So the key is being able to get the executives and leadership involved and engaged, and then get that drill down so that you can get to those insights. Good news for OU is that you are on the road, on the path to being able to get to those insights. I really look for at least one report writer writing more than 1,000 reports in a year's time frame. We're sitting here in November. You haven't had this for a year yet. I think you started it in February. something like that. So you've already got Tennille, who's written more than 1,000 reports, and you've got a couple of other folks that are getting very close. You have 45 total individuals that have been on the CDB, and you've got over 3,500 reports. That to me is an excellent, excellent start that you have. Now, the key is to harness this, is to figure out, okay, what are we writing? What are we doing? How are we setting this up? I know that you're moving towards kind of service line leadership, which is fabulous, getting those dashboards out of the service lines, helping them drill down to be able to understand where they need to improve. But I have no concern that you're not going to be an organization that is not writing reports. And you've also got the A team in terms of the OQE over there with Christina, who's going to make sure of that as well. Okay. Quality and accountability study. I've talked about it. It's the ranking. How many of you, by show of hands, know or have heard where you were ranked? Okay. Well, guess what? I'm not going to tell you where you're ranked. And that's because it's your first time in the Q&A. I don't want you to be focusing on that. What I want you to focus on are the metrics within the quality and accountability study where you had a Z-score. That's the score that is in the parentheses greater than 1.5. A Z-score can be like a standard deviation, so that when you look at your standard deviation greater than 1.5, to me, that is statistically significantly different than the other academic medical centers. And by the way, we have this for Edmond as well, and we can go through that at some point in time. But Edmond, I'll just tell you that they were kind of in the middle for most of the metrics, except for cost, and we'll get to cost in just a little bit. So every Z-score that you have that's greater than 1.5, I've listed there, which includes a lot of the mortality service lines. We look at about 17 different service lines, I think, and so a handful of those had Z-scores greater than 1.5, including gastroenterology, which had a Z-score of 4.5. So that 4.5 standard deviations away from the mean is huge. And so we're going to drill down a little bit and take a look at that. You can see efficiency. We've got cost, some of your cost metrics. Those are the ODE ratios, the first numbers, and then the things in the parentheses. And then length of stay, OB, at 6.35. That's going to be an easy one to be able to decipher. I kind of figured this out before I even wrote the reports, but you'll see the reports here in just a second. The safety one is the one that concerns me the most. You would think it'd be mortality, but it's really the safety one, because one of the founders of this study, Dr. Mark Kerouac, that some of us know very well, basically said, this is the open book part of the test, meaning that the safety domains are the ARC indicators, the Nissen indicators that you can see there, the infection control. And so for PSI 6, which is iatrogenic pneumothorax, and for PSI 11, which is post-op respiratory failure, you have very high Z-scores away from the mean. Typically, what we've seen over time with our academic medical centers is a regression to the mean, meaning that there's very few of our organizations and PSIs and Nissens that are beyond 1.5. And you're at 3.1 and at 2.6 and at 1.9 and at 5.8 for the Nissen. And that's because people are focusing on these. They're looking at them in terms of data quality, in terms of throughput, and in terms of harm. Remember, some of it could be that you're missing an inclusion or an exclusion in coding, but some of them are true. They're happening. They're what's going on in your organization. We've got to figure those out. And when you see spikes in those, typically people double down on reducing that. So that's the one that I would say that concerns me the most of all of these. Excess days. We'll look into an excess days example here in just a second. And we've got some lab value information transfusion and some outpatient revisits for biliary. Typically that biliary just means low volumes. And so you have to look at that information when we drill down. And then patient centeredness. These are your HCAP scores that we get from your patient satisfaction vendor, and your discharge, which the top box, which is the would recommend and highly would recommend, are 81%. That's 2.6 away from the mean. And so again, to improve that, obviously you would go and take a look at your discharge processes. So let's drill down into some of these a little bit more to try to get an understanding of why. The first thing I did, though, before that is to say, okay, this was based on the last 2 quarters of 2021, the first 2 quarters of 2022. So let's see if there's been some movement in the Q3 of 2022. And you can see still against the AMC. So the focus is you, the comparison is the academic medical center mean. And you can see mortality comes out bright red, as does percent of early deaths, by the way, and direct cost, many of those, but doing fairly well in terms of overall complications and then length of stay index. So maybe there's been some work done already on those overall complications. This does not include the overall complications, by the way, the Nissen information. It's just the ARC indicators, the hospital-acquired conditions by CMS that we're going to get into just a second. But here's the gastroenterology mortality. Your volumes are staying the same. So the one thing I look at is whether your volumes have fluctuated, and then I'll go in to see different base MSDRGs or clinical conditions to say, oh, maybe it's because you're bringing in a patient cohort that's a lot sicker, and that's why patients are dying. But your volumes haven't fluctuated. Your volumes within the base MSDRGs haven't fluctuated. What has increased, you can see, is your observed mortality. Your observed mortality in gastroenterology over the last year and a half has increased. And these are not huge numbers. These are, a couple more in each quarter. But it does bring that observed mortality up, and that's what's really driving your gastroenterology mortality. It's not the expected, although, there's some work that maybe you could do on your expected, which is the green line. It's not the expected, it's the observed. There's more gastroenterology patients dying in the hospital than there were a couple of years ago. And you can drill down to take a look at those patients. These are the deaths that occurred over the last year. And you can see those that I've highlighted in our risk adjustment that are below or well below. That means that they had low expected values, but they died anyway. And a couple of these, might be because you're not giving us the diagnoses that we need to be able to increase those expected values. But you know what? A couple of them are fall into the category of what I term deaths in low severity base MSDRGs. This is something overall that you'll see that OU Medical Center has an opportunity in. Now, again, there's 3 reasons why this is going to occur, the deaths in the low severity base MSDRGs. Number 1 is data quality. So, for example, the principal diagnosis, the first diagnosis of this patient that died in the hospital was residual hemorrhoidal skin tags. That's the principal reason why the patient was to be admitted into the hospital. However, the second diagnosis, which is what's called an MCC, major comorbid condition by CMS, was metabolic encephalopathy. You've got then 3 other MCCs, post-acute respiratory failure, kidney failure. You can see all of those were no. That second column, present on admission, no, which means that we can't use them for risk adjustment. CMS can't use them for risk adjustment or to help pay for you because they weren't present on admission. So a couple of reasons why this case could have died is, or in a low severity base MSDRG, is first and foremost, that first diagnosis. Is that the right diagnosis? Is that the real reason why you admitted this patient? Second is throughput. Patient was in the hospital for 14 days. Why was the patient in the hospital for 14 days? And there's a lot of things that happened to him. Was there a complication that occurred that resulted in acute respiratory failure? Or did the patient have acute respiratory failure because they were a transfer from another hospital and you just didn't get enough information on admission to be able to categorize those as yes? So you get a sense here of all of those 3 aspects. Data quality could be the principal diagnosis, could be the present on admission status, throughput, patient was in the hospital for 14 days, and harm. Was there a complication that resulted in the acute respiratory failure that included resulted in hepatic failure without coma? All of those that are present on admission, no. So that's when we talk about mortality reviews. We want you to not only just look at this patient, because if you look at this patient, you saw all of those diagnoses. This patient was really sick. or got really sick once they got to the hospital. That's the question. But most people would say, okay, yeah, this patient was sick. You need to look at this patient in all three of those aspects: the data quality, the throughput, and the harm. OB, as I mentioned before I even started writing the reports, I kind of understood what was going on here. Your normal deliveries and your normal C-sections occur in this hospital. They don't, meaning that when we get your information, you've split out OU children's with the adult. The normal deliveries and the normal C-sections come in through the OU children's, not through OU Medical Center, which means that we only had in the last year 14 C-sections and vaginal deliveries done at OU Medical Center. Those are those very high-risk ones that need to stay in the hospital quite a bit. That's the reason for your long lengths of stay, your long costs, your high costs in this organization in OU Medical Center for OB. So there's two things that we can do to be able to remedy that. The first is I've already contacted our folks that run the Q&A study at Vizient, and I've said for OU Medical Center, there needs to be a normal volume or a volume amount that anybody who has volumes below this just does not get scored in OB. That could be the case because you only had 19 cases per quarter in OB. So the volume could be a threshold of 40 or something. Then you wouldn't be scored in any of this. Or we could take your normal deliveries and your C-sections and move them over somehow in the data to be able to make sure that all of these wash out essentially. Because when I did look at your OU children's, there are thousands of those. So they would wash out. So this is really an issue that we need to be able to deal with. Why? Because if we don't deal with it, it's going to affect negatively your score in the Q&A. Now, it's not going to affect it by 5, 10 ranking points. It might affect it by one ranking point or 2 ranking points. But we do need to make sure that we figure this out. So we will do that. Again, the concern that I have in the safety domain is that these might be real. You've seen an increase in iatrogenic pneumothorax in the last couple of years, some spikes. Note also on the very top that there's not many of them. There's 4, 6, 2, 1, 4, 3, 2. Those are the number of patients. But again, this is where most of our organizations, when they see these spikes, are doubling down on this, are going in and saying, what's going on here? We've got to get this back down to where the average of the academic medical centers are. And so that's something where we're going to really work on in the visioning this afternoon, and everything else is really drilling into these and trying to understand what's happening here, what's happening with the post-op respiratory failure, and what's happening with your CODIs and CLABSIs, because I understand that you've done some work to improve CODIs and CLABSIs, and that's great, but they're still greater than 1.5 standard deviations away from the mean from other academic medical centers. So we want to keep pushing complications down at OU Med Center. All right, we having fun yet? Isn't this fun and exciting? All right, so again, we're going to go back to the data quality, throughput, and harm. I'm going to focus on data quality now, and just talk to you a little bit about some of the things that this means. And some of you have already seen a lot of this information, but I'm going to start with just the number of diagnoses that you're sending to us per case. We're going to compare it to the academic medical centers, and you can see the length of stay expected values there as well that correlate with the number of diagnoses sent per case, because the more diagnoses you send per case, the greater chance we have of getting those predictors for long lengths of stay that increase that expected value, which in turn then lowers the ODE ratio. And you can see that for your gastro patients, 16 diagnoses per case. You can see the AMCs and then the large specialized complex care medical centers that we added in here as well. They're sending us 17.8. So they're sending us about 2 more diagnoses per case. They have a 4.5 length of stay expected value. Yours is about 4.2. So one of the things that you really want to do is you want to get to the point where you feel comfortable that you are capturing the true severity of your patients. because you're lower than the average of all academic medical centers and large specialist complex care medical centers in length of stay for most of those service lines, and you shouldn't be. You should be at or above that. And that's your goal, is to be able to get at or above that. Coders, though, I will tell you that they don't see predictors. They don't care about predictors of length of stay, cost, and mortality. What they care about is the CCs and MCCs. Those are, again, comorbid conditions or major comorbid conditions. They're developed by CMS to be able to help in reimbursement, because that's what the coders are focused on, is getting reimbursement. Now, the good news is most of our predictors are also CCs and MCCs. And so the other good news is we have reports that, like this one, that can tell you where you have true opportunities in the capture rate of CCs and MCCs, and you do in cardiac surgery, neurosurgery, and oncology, where you are lower than the median in terms of those capture rates. So this gives you a sense to work with those HIM department and the coders to say, let's do a focused effort on neurosurgery or on oncology or on cardiac surgery to be able to get those CCs and MCCs up, which will in turn get the predictors up, in turn will get the expected values up, in turn lower the ODE ratio. This is new, so I just wanted to show you where you've been in terms of diagnoses per case over time, and then where you are in mortality expected. Now, the interesting thing for diagnoses per case is that there was a huge increase in 2020. I don't know if that had to do with COVID or if that had to do with a focused effort. You can see that the AMC line, the green line, has just been steadily going up, essentially. And this flattened out a little bit over the last couple of quarters, but it's essentially going up. But whatever happened with OU in terms of diagnoses per case, we went back down to kind of the norm. And now the green line is outpacing your line. So essentially what we need to do is we need to rectify that. We need to get to the point where you're getting us more diagnoses per case. Now, the good news is your expected value overall for mortality is above where we see the academic medical centers. But again, a couple more of those diagnoses will increase the mortality expected. Now, your length of stay expected is lagging a little bit behind. You'll see that here in just a little bit. This goes to the point that I want to make to a lot of organizations. When I present to them, will grab on to this idea of data quality and say, our poor performance or our performance is due almost solely to poor documentation and coding. And while you have opportunity in documentation and coding, I will tell you that that is not your major focus. You have to be able to get that expected values farther up. You have to get your diagnoses up, but yours are going to be in throughput and harm as much as they are. Going back to that overall mortality rate of 5.9% compared to other organizations, which are at around 3%. We'll get into some of those here in just a second. How do you drill down into this? You go into our risk models, which again are very specific. We do them by clinical condition. This is the heart failure mortality model, where we only model heart failure patients, 214,000 of those patients. And we find out that vent on admission day, DNR, severe brain conditions, and shock are the strongest predictors for mortality in heart failure patients. And so then you can go down to be able to increase the expected values of heart failure patients by saying, what percentage of the time are we capturing severe brain conditions versus other organizations? And if it's lower, then you can go and you can do a focused intervention and change on getting more severe brain conditions, seeing your expected values go up. Now, we have 400 of these models for mortality, 400 for length of stay, 400 for cost that are updated every year. So this is a full-time job for someone to go through all of these. So we've done a lot of the work for you and given you a cheat sheet of the top 10 variables. Again, most of these are going to be what are called CCs and MCCs to be able to help you focus more. You saw this last time I was here in May, where you are capturing less than the 50th percentile against these organizations in all three of our top predictors: acute renal failure, fluid and electrolyte disorders, malnutrition, And you can see some of these, again, wouldn't necessarily be ones that you'd want to compare against, but you're lower in capture rate of these than those, which means that they're probably getting higher expected values than you are, the Herman Memorial Cities and the Methodist Sugarlands. Now, one of the things that we notice all the time when I do this is everybody always focuses on malnutrition for some reason. It's because CMS always says, malnutrition, don't do that because you're going to be on the radar for us. I know that was something that you all did, and there is signs of life. There are signs of life that you've increased the capture rate of malnutrition, which is good. Now, I will tell you, I did the same graph with fluid and electrolyte disorders and acute renal failure and did not see that increase. So now it's time to not only take your foot off the gas of malnutrition because you're not still where you need to be against other academic medical centers. This is of all patients. The one before that was just of medical patients, but also now focus energies on fluid and electrolyte disorders, acute renal failure, to be able to get those expected values up. When we look at your highest mortality opportunities by what we call base MSDRG or clinical condition, we see some very low expected values. These are expected values essentially that will tell you that we don't see a lot of deaths in those base MSDRGs. These are the ones that are red over here, the esophagitis and the diabetes. Those are clinical conditions that are low severity clinical conditions. When patients come in to our organizations, our 1,100 organizations, they typically don't die. So what we want you to do is, like we've done before with that oncology or that gastroenterology patient, is to drill down into these patients to really understand, again, data quality, throughput, and harm. This is that esophagitis patient. A couple of things again here. You've got the end-stage renal disease as the second diagnosis. Nausea with vomiting unspecified was the first diagnosis. So that was the reason why that coder determined this patient should be admitted. Typically, nausea with vomiting, those patients don't die in the hospital. This patient did, but I would suggest maybe the end-stage renal disease should have been that first diagnosis, which would have increased the expected value, which would have increased the reimbursement for this patient. But then there are a couple of other things you want to look at this patient. They were in the hospital for 20 days again. So that is one of those patients that throughput comes into play. And then you also have some no for post-op respiratory failure, a cerebral infarction. So you want to look for complications or what happened in the stay that led to those. So data quality, throughput, and harm when you're doing any of these types of work. I mentioned on the one of the first slides that you have as one of the bullet points summary to be able to reduce the number of deaths that you see in low severity base MSDRGs, because you're 217th out of 226 hospitals that have a certain volume in these low severity base MSDRGs. So 41 of your patients during this time frame died in those low severity base MSDRGs. And if you look at the top hospitals, the hospitals that have the lowest percent mortality among patients in low severity base MSDRGs that die, all of those in green were top in the quality and accountability study. And NYU Brooklyn, this was last year's 2021, but NYU Brooklyn was top in the quality and accountability study in 2022. So even though the quality and accountability study has efficiency measures and patient-centeredness measures and operational measures, how you do in making sure that you're really focusing on reducing mortality in these low severity base MSDRGs goes a long way in how you're going to do in that quality and accountability study. Oh, good. Yeah, thank you. That's right. It's essentially every clinical condition that has less than a 1% mortality rate in our database. Throughput. If there was one metric that I would encourage every organization to really focus a time and attention on, it's throughput or length of stay, not just long lengths of stay, but these early deaths, to be able to understand how to drive improvement in their organization. Early deaths, again, are patients that are admitted and then die within 48 hours after being admitted. And you can see when we look at sepsis patients, again, look at I've sorted it by mortality index, that ODE ratio. Your sepsis ODE ratio is 1.11. You can see the best ones over on the left-hand side, all of which, now that NYU Brooklyn is in the top of their cohort, are in the top of the quality and accountability study. Again, how you do in sepsis mortality goes a long way in how you do in the overall quality and accountability study. What we look at here for OU Medical Center is that 115 patients that were coded as sepsis patients died in the hospital over this year's time frame. That's 15.75% of your overall patients. 7% of those, so roughly half of those patients, so roughly, what is that, 60, maybe, yeah, 60 patients or 50 patients, 55 patients of those 115 died early. They were typically patients that are very sick coming into your ED. You admitted them, and then within 2 days, they died. Now, remember also that we looked at the overall profile at OU Medical Center, where it's the first 5 days that it seems that these patients are dying. We're only looking at the first 2 days at 7.12. If we got to the first 5, it might be 10%. It might be 11 or 12% of your patients are dying within 5 days after coming in. Now, the other thing to note is that 15.75%, which is quite a bit higher, 3 times as high as what you see from the top organizations in terms of death. And so that's something else you want to be able to drill down into. But how are some organizations reducing early deaths? And this is, to be fair, the most controversial slide I will have in the deck. But it's looking at your deaths that occur in the emergency department. Now, how does a patient die in the emergency department? Typically, it's because they are very near death when they come into the ED, and it's just not worth putting them up into the floors, or you don't have capacity to get them into certain floors, so they die in the emergency department. What a lot of organizations are doing is they're starting to say, is that a bad thing for our patients to die in the ED? And their answer is yes, if the services aren't there to take care of those patients. So we all know that if a patient comes in near death into the ED, it's very difficult for the ED staff to be able to say to the family, in particular, we're going to take this patient and move them directly to a hospice. And it's also very difficult for them to get a bed in a hospice for a patient that is near death. So organizations like Herman have developed what they call the waterfall program, where they are bringing services down for those very near death patients into the ED and their families. And those patients may stay in the ED 1 or 2 days. And they've got chaplain services, they've got palliative care, they've got all the other services needed to be able to take care of those patients. That's something where they've decided, we don't want to be able to put this patient up onto the floor because it might be worse for the patient, for the family, and the clinicians. Because I was at St. Barnabas Medical Center in Livingston, New Jersey, and the ED said, yeah, we don't have deaths because we have capacity in our organization, and we're putting those patients up into the floors. And there was a critical care physician in the room who said, we've got to stop that, because I'm seeing patients all the time that are so close to death. I'm not comfortable taking care of those patients and their families. I'm trying to get palliative care in, but they're not there by the time this patient dies. And so a lot of organizations are rethinking what they do with these patients that come in that are near death. And that's something that is really challenging to do, but it is also something that a lot of organizations are starting to say, the best thing for these patients is not to get them up into the ICU and to hook them up with everything to try to do a lot of that fetal care. I'm not trying to say that you shouldn't be trying to save some of these patients, but I do know that when you go to the ED staff, the physicians, the nurses, many of them will say, we knew this patient was going to die in the next day or so. So there's different ways of thinking about how to be able to take care of those patients. No. Thank you for that. They're not being, the question was whether they are being admitted into the hospital. The answer is no. They are not being admitted into the hospital. None of that paperwork is being done. They're staying in the emergency department. You're absolutely right. You don't get that payment for the inpatient. And so you have to include finance. In fact, Memorial Hermann actually developed a supportive care unit right off of the ED. That was an observation unit where they put these patients. 98% of those patients did die in the 2 days, but they stopped that because they realized that in Texas, if a patient goes to observation, then the family is required to pay something like 80% of that visit, where if they were put in inpatient, they weren't. So you have to involve finance, you have to involve operations in doing this. But the other thing that it doesn't do is it doesn't show up as an inpatient mortality. Yeah. So it has revenue implications, it has operational implications. It's one of the reasons why it's challenging to really think about how to be able to handle some of those patients. But it is a topic of conversation in hospitals now. What do we do with what's the best thing to do for these patients? But you have to have finance involved, absolutely. They did. Correct. There is. And I will say that hospice gets removed, but they don't get removed automatically. So Geisinger just came into the database and their observed mortality was high, and they went in and said, well, these are hospice patients. There's a hospice flag that the IT folks need to be able to check to say these are hospice patients. And so that's something you might check if you do have hospice beds in the hospital, whether or not those patients are being checked as hospice patients. Yep.
Transfer to hospice, but that mortality counts against the hospital. So CMS makes the assumption that
that's right. Yeah, and that is, to me, the better way to look at it, to be quite honest. We just don't get all of the hospice. We only get the hospice that the hospitals send to us. So we can't determine, if you send to an outside hospice, whether that happens. CMS has that information so that they can do that. To me, it's where's the best place for this patient to be, and if it's in hospice and that positively affects our metric, then that's good. But there are revenue implications that you have to keep in mind. CMS came up with a metric a number of years ago called excess days that they now use in their CMS STARS program. And so we did the same. We came up with excess days in our database, and you're able to go in and drill down and take a look at this. Now, CMS came up with a metric, I believe, to be able to bring in hospital-based outpatient information. You can see those two revisit columns: revisit days observation, revisit days ED. My belief was that CMS built this to be able to help bring in those hospital-based outpatients informations in here. And I will tell you, after all the analysis that I've done, that the main factor for the excess days is not revisits. It's not readmission rate. You can see the readmission rate, percent readmit, varies as we go along. Those are the top 10 in excess days, and they all have a much higher readmission rate than you do. It is the length of stay of the readmitted patients and the expected length of stay of the readmitted patients that are really driving excess days. So the only focus on here for this is that you do have one where neurosurgery, where you have a Z-score greater than 1.5. And so it's going to be the length of stay and the expected value of the length of stay of those neurosurgery patients that's driving that 1.5. Not the percent readmits or observation. Not to say that you shouldn't look at that. It's just that I guarantee you that that's what it's going to be. So I just wanted to let you know that when you hear excess days, it really is a throughput metric. It's not a percent being coming back into the observation or ED. All right, as when we look at length of stay overall, you can see the overall length of stay observed on the top compared to the academic medical centers looks good for cardiology, general medicine, and neurology patients. It's really where your expected values are lagging. Remember what we saw for mortality. It was a little different. Your expected values were on par with the AMCs, but your observed values were higher. So it's a little bit different here. So this one's going to be for length of stay. I would focus your coding and documentation efforts on that top 10 in the length of stay bucket rather than the mortality bucket to be able to improve length of stay. Now, overall, I just want to tell you your length of stay is good. It's not terrible. It's not great. Now, what I've done here is I've compared you against some of the better hospitals in length of stay. And what we see here is the percent of patients that are, this is for a different time frame than what I showed you earlier, but percent of patients that are going home on a routine basis to these post-acute care or expired. And then also in parentheses, you see 5, which is the length of stay observed, and 4.8, which is the length of stay expected. And the bottom line of this graph is that when you're looking to improve length of stay, don't focus on your routine to home patients, because you're at 5. Well, you should focus on shaving off about half a day of those, but 68% of those are going home in 5 days. For you, that's going to be an effort to be able to shave about half a day off to get down to 4.5, 4.3, closer to where you see Northwestern, Mayo Clinic. It's really trying to reduce the difference between the days that it takes to get a patient out to home routine versus to home health, SNF, and hospice. And also to look at your expired. Now, your expired, those patients are dying in on average 8.4 days. Look at your expected value for the expired patients, 7.3 versus the 10, 11, and everything else. So again, overall, your expected values look pretty good compared to AMCs, but not when it comes to those patients that are dying. And those patients that are dying, there's a lot lower expected values. Why? Well, we talked about one of the reasons. There's a lot of patients dying in those low severity base MSDRGs, which is bringing this down, that you need to take a look at. The other thing that I've highlighted is the 4.5%. It was 5.9% for a different time frame. It's 4.5% here, still much higher than what you see from Northwestern, Mayo, Methodist, and Intermountain. IHC is Intermountain, their main hospital. So that is something, again, that we've talked about. Your observed mortality is higher. You have much lower percent of patients going to home with home health. Now here's the challenge with that. The average time it takes to get a patient out to home with home health is 7.4 days, where it's only 5 days to get them home with that. So whether that's because you have poor access to home health, whether that's because they're staying in the hospital 2 extra days in order to do all the paperwork necessary to get them to home health, whether that's because you're only taking those patients that are really sick that don't need post-acute care to home health, you got to look into that. Don't automatically start sending more patients to home with home health until you figure that out, because then your overall length of stay goes up at 7.4. We're doing a little construction behind me. So that's some of the things that you want to glean from here. Your expected values are a little bit lower, particularly in expired. Your expired observed is higher. 12.7 days to get to hospice. 7% of those patients getting to hospice. That's quite high. So again, that is 7 days greater. So these patients need to be in the hospital probably a couple more days. But I know that there's some issues with getting patients out to hospice. All right. What are some organizations doing to rectify this? University of Texas Medical Branch in 2016 and 2017 timeframe did 2 things. They hired more case managers. So a case manager saw every patient every day in the hospital, and their only focus was, when is this patient going to get out of the hospital? What do I need to do today, even before I'm being told this patient is going to be going out of the hospital to get them out when the patient's ready and not when the post-acute care ready, and then develop better relationships with post-acute care. Bought a home health agency because they had an issue with current home health agencies that they did. Added more rehab beds, added hospice beds into the hospital to get them there. Placed their EMR in a local SNF and rounded on those patients once they were there because they were seeing higher readmissions. So they did a lot of these different things to help develop those relationships. Very similar to what we see in Canada. Now, Canada is on a global budget, and that means that they have their expense line given to them for the next year. And I was talking to the CEO of Ottawa Hospital, a large academic up there, and I said to him, what happens if you have certain patients that are in the hospital for 45 days and they take up all of these resources, and by September you've blown through your budget? And he said, that's when we get fired. And he wasn't joking when he said that, even though he did kind of laugh afterwards. So what they've done is that they have built post-acute care towers, they call them, right across the street from their acute care tower. And when that patient is not needed to be in the most expensive chassis, they are moving them to that less expensive chassis. Sure, they have hospice beds and SNF beds even over there and everything else, but they have transitional beds. They have beds where it's not 1 to 5, it's 1 to 10. The nurse to patient ratio. So getting these patients, thinking about where the best place is for these patients, and it works out for them because it's much lower cost environment for them. If you haven't followed what's happening in Atlanta, Wellstar Atlanta Hospital is down in the city of Atlanta. Wellstar's in the database, and when they saw the performance of Wellstar Atlanta Hospital, they started to say, well, why do we even have this open? Why? Because Grady is downtown Atlanta. Grady is the safety net hospital in Atlanta that gets money from the counties and the government to be able to stay open. Atlanta Medical Center does not, but Atlanta Medical Center is about a mile away. And what a lot of the indigent patients have found is that access is easier and care might be a little bit better at Atlanta Medical Center. So Atlanta Medical Center sees over 50% indigent Medicaid and county. These are the patients that should be going to Grady, but are not. Wellstar about 3 months ago made the determination they're closing Atlanta Medical Center. They said that this is not the business we're in, it's the business Grady's in, so we're closing it. The government reacted by saying to Grady, we're going to give you $200 million more to take care of these patients that are now going to be coming to you from Grady. What was the first thing that their administrative and their leadership said? Well, good, we need that $200 million to build more inpatient beds. And what we're trying to do is trying to tell them at Vizient, hold on. What if you build this kind of a model that Canada has? Because if you go into Grady right now, they have a high percentage of their patients that are there over 40 days, over 50 days. These are patients that they just can't get out into the community, and they are holding a bed hostage as well. So one of the things that East Carolina did once they got back into the database is they've started going into their hospitals and getting a sense of which are the patients that don't need to be in this most expensive chassis right now. And they're finding some incredible numbers. At their academic medical center, they're saying up to 40% of their patients may not need the care that an academic medical center provides or the inpatient side provides. Another example is, again, we'll go back to West Virginia University and a command center that they built. The command center, most organizations build. They built it right before COVID. They didn't build it as a result of COVID, but it was right before and it helped them through COVID. But it is quite remarkable in what it's done to lower the length of stay observed. Remember, I told you, look at the academic medical center length of stay, the green bar. Over time, it's going up. That's the observed length of stay of all patients. Theirs has gone down. And why? When they instituted that command center for their not only their system, but for a look at everywhere else, they have a physician presence there 18 hours a day. There are 20 stations in that command center. They've got EMS, they've got environmental nurse supervisors. It's an expensive proposition that they've been able to do. But as you've seen earlier, their transfers from other hospitals have declined. Their length of stay has declined. They have moved in the quality and accountability study from the 40s to the 20s. And a lot of it is because of the work that they do here at West Virginia, at this command center. Now, they're not getting all of their transfers in from hospitals from their system. Their system now has about 16 hospitals. The first thing they did with those hospitals when they purchased them, put their version of Epic in that hospital. So that command center then has a window into every single one of those hospitals. But not all of them come from those hospitals. So they're constantly on the phone with other hospitals that are trying to send data here. This is the one where a physician has gone out to every one of these hospitals that send them patients to talk about, is there something we can do to keep some of these patients here? Is there something we can do like telemedicine or add services to be able to make sure that they're rationalizing the throughput throughout the state of West Virginia, really. Okay, and then harm, and then we'll stop. Harm, the first thing that comes to my mind when I think of harm in the hospitals is hospital complications, which is why I mentioned to you that you have now 6 sets of complications to drill down into. Yes, those 6 sets of complications are coded complications. And that's, for some organizations will say, well, we don't really care about those because there's this huge effect on coding. I would say to them, take a look at the hospital-acquired conditions and the patient safety indicators that our general surgery patients have. Here at OU Medical Center, it's 43 of those general surgery patients over the last year, the year ending Q3 2022. That's 3.3% of those general surgery patients, which is higher than any of these other hospitals. Now, granted, these other hospitals are the top of our academic medical centers in the Q&A. So you are seeing more patients, more general surgery patients with an ARC patient safety indicator or a hospital-acquired conditions. And again, if you're saying, well, those are coded complications, the difference in direct cost by patient is over $67,000 for these. So if you're able to get that 3.3% down to 1.5%, where Utah is, and cut those in half, that's also a huge savings to the organizations. It's also going to reduce your ODE ratio for mortality. It's also going to reduce your length of stay, because the length of stay index and the mortality index for these patients is also much higher. So if you haven't already, double down on safety is one of the things that I would suggest for you. Get yourself a king or queen of complications. I know that is probably not the title you want to use, but get one of those who's going to be looking at data quality, throughput, and harm for all of those sets of complications, not just CODIs and CLABSIs, but all the ARC patient safety indicators, also hospital-acquired conditions. Readmissions, readmissions, the one message I'll have for you to readmissions is drill down into these to understand who your friendly faces are, because they might not be necessarily who you think they are. Your readmissions don't always track the highest readmissions with CMS's clinical conditions that they have, like your disease of the liver, alcoholic hepatitis patients, where this patient came in, looks like 12 times. Get to know who these patients are. Develop tailored interventions. You'll find that the interventions that you want to use to reduce cirrhosis, alcoholic hepatitis readmissions, which is your highest percentage readmission, is going to be different than what you would do for heart failure or shock, and it might involve some community resources. And then also, when I say double down on harm in terms of complications, double down also on who are these patients that are leaving the hospital and then being readmitted within 3 days. Really understand them to really figure out what we can do to reduce the readmission rate within 3 days. Some of them, yes, you would say maybe we need to keep these patients in the hospital rather than leave them and have them as a readmission. So you're going to have length of stay differences, but still really understand this. A lot of organizations are moving to what I would call a harm index. A harm index includes not just those complications, but it includes 3-day readmissions. It includes deaths that are occurring in low severity base MSDRGs. And how it's being presented on a monthly or quarterly basis is the number of patients that were harmed that either had one of these complications, came back within 3 days, or died in the low severity base MSDRG. And then finally, we'll talk just briefly about cost and utilization. We do have cost in the database. As I mentioned, it's a ratio of cost to charges. The good news is that you can drill down into it by what I call bucket or service group to really see what's the difference in terms of your cost against other organizations. I mentioned we had Edmunds information. When we look at Edmunds' overall quality and accountability study, the one area that is highly negative in terms of their Z-scores opportunities is direct cost per case. General medicine, which is what you have here, is one of those areas where the Z-score, I think, is about 2.3. And when you take a look at that, you want to be able to drill down and understand why. The difference is in accommodations cost. When we look at the top community hospitals at $2,581 for accommodations. At Edmond, it's $5,729, a difference of $3,148. Well, then you drill down into the database to see if it's in fact the case, and you can see higher length of stay, higher ICU, but I don't think it's $3,148 worth. Did you want to say anything, Jonathan? So that's a great question. Is it just an issue of scale? The answer, it could be. That absolutely is a great thought, and it absolutely could be. It also could be that you're filling out the ratio of cost to charge worksheet differently. Remember, this is the CMS cost. You have to fill out a ratio cost to charge worksheet. If the finance folks were here, they would say, we don't like this cost because we think it's muddy in terms of this, but you get to drill down and understand this. And let me give you an example. NYU saw their accommodation costs higher than the other academic medical centers. And they went in and found out that they were adding in cardiologists' salaries into the ratio of cost to charge worksheet. And they were like, well, we shouldn't be doing that. So they took that out and they were able to do this. So you can drill down. We've helped other organizations do this to understand if it's a scale issue, which you're absolutely right, it could be because of the volumes. Or is it real, or is it, that old commercial, I'm dating myself, is it live or is it Memorex? We can say if it's real or not. So there's value of seeing this. Why is there value in seeing this? Is because this is the same cost Medicare is seeing. So if we're seeing Edmond having really huge opportunities in cost, so is Medicare. And by the way, OU Medical Center also has opportunities in cost. So you want to be able to take a look at that. Some notes right now. Now, I would say this. You still have a length of stay opportunity for general medicine patients in ICU, but I don't think it's $3,148 difference than those. It could be scale, it could be that, but you're absolutely on the right path of understanding this. My favorite part in the database, and I'll end with this, is the utilization component. It is something that I didn't get to show you in May because it wasn't ready, but it is ready for you now. You get to drill down in over 2,000 drugs, in over 300 lab tests, in radiology tests, blood products, ancillary services, radiopharmaceuticals, CV services, to be able to take a look at where you are compared to other organizations. It is a gold mine, but it is also the ocean. You dive into this and you're like, where do I begin? Where do I start? So we've given you 2 pages of use cases to start. And I'll tell you a couple of other stories. Rush in Chicago, where I live, their P&T committee. Every P&T committee, they bring a drug that the database suggests that they overutilize, and they talk about interventions to reduce the utilization of it. And in 1 year, looking at 12 drugs, they were able to save over $1 million. Mayo, take a look at the database, and they looked at their labs and looked at standing orders. And they went to their physician and said, we want to be able to reduce standing orders. Most of the physicians said, we didn't even know they were standing orders. We're just hitting a button. So they were able to get some low-hanging fruit to reduce these. We can look at reducing IV acetaminophen across surgical DRGs. You can look at reducing chest x-rays among heart failure patients. Again, 2 pages of use cases to get started in this. We also have template reports that you can go easily and grab, like OU's sepsis drug utilization. And you can see what are the top drugs that you're utilizing more than other organizations, what percentage of your cases are getting it, how many days they're getting it, what's the actual variance. Now, the variance here is not ratio of cost to charges. It's what we call DDD, defined daily dose, which is the World Health Organization's wholesale cost for these drugs that we attach to each of these drugs. So it's the wholesale cost. You're not paying the wholesale cost. We know that. So that when you add all of these up and you see about $120,000, you're not going to get $120,000, but you're going to certainly get, maybe just for sepsis patients looking at these drugs, getting to the variance $80,000 maybe of true savings in terms of this. You can drill down by physician, the discharge physician, the procedure physician, to really look at who's doing this. You can drill down into any hospital that you want. So you can say, OU Medical Center, I want to look at University of Arkansas Medical Center, and you want to compare yourself to them. And then the lab utilization, again, same thing. Now, the only difference here is we have these funky numbers called resource intensity per unit. So for drugs, we're using DDD. For lab, radiology tests, blood products, ancillary services, those types of things, we're using resource intensity, which we've developed from the HCPCS codes. So all you need to know is that the higher the RI per unit, the higher the cost it is to do that particular item. So it is a fabulous tool to be able to reduce clinical variation, to be able to take a look at this and really start to get at what, again, Don Berwick has told us could achieve at least a minimum of 25% savings in our expenses, which is really truly getting at reducing clinical variation. Again, we're going to talk more about this in the afternoon, about how to really engage in this tool and everything else. But I will end my presentation there and ask for any comments, questions. Ask Rick and Jonathan if there was something that you heard yesterday from me that you wanted me to mention, any of that.
No, I really appreciate it. I think that I think the other message that's important is
Yes. Yep. Very, very well said. It's a good comment on the, again, a lot of organizations believe they can get where they want to be in the study just by focusing on coding and documentation. And the answer is they're not even close. You need to work on both. You need to feel comfortable about where you are with your expected values. But here, the 2 things that really pointed out to me that of opportunity areas are the observed mortality that you have at OU Medical Center, and then the observed complications, the ARC complications, the Nissen complications, and the HACs that you have here. Those are the 2 things that we really need to double down on to really understand and improve. Yes.
I'm happy to see the number that you showed that the admission rate is low, the overall that they average is high. and some factors are like out of our control in a way that it would have some outlier of the staying for 3 or 4 months, even in the ICU.
Yeah.
Other conditions about disrupting heart attack. One patient has been reported for the that is due to average. They're away with the database for the median, other factors.
Absolutely. We have what we call length of stay outliers, and there's a radio button that you can exclude all length of stay outliers. Those are the patients staying at the 99th percentile. Or you can just go in and you can create your own and say, I want to, exclude everybody that had a length of stay above this day. We also have geometric mean length of stay. So the geometric mean length of stay essentially takes off the tails as well, a little bit more than the 99th percentile. So all of those you can take a look at. It's a great question and a great point when we talk about these patients. It's one of the reasons why when we look at CMS stars or a lot of these national programs that compare you to even Edmond, it's not a comparison. When you look at the academic medical centers versus other organizations, we're going to see more of those patients, which is why the AMCs need to be more creative in thinking about what do we do with those patients so that we don't keep them in, which is why I've always said that the organization that follows that Canadian model first. Now, again, it's easier said than done because you've got financial issues, you've got operational issues and everything else. But whoever can get to that point their performance is going to look really solid. Now, I will also say that to another point made earlier, CMS looks at 30-day stuff because they can, and we cannot. But to me, that's better for the patient if they're rather than being in the hospital for 40 days to be somewhere that's better for them. By the way, University of Vermont is starting to do some of that work. They've bought 6 mom and pop hotels that have gone under in Burlington with the thought of we're going to put them into transitional housing, meaning patients that don't need to be in the hospital can go there. Now, they haven't fully figured out how to do that yet, but they're on their way. Yes. Yes. We're yep. Yes and yes. So yes, you can do that, and that's what we're going to work to do for you, is to get you that compare group that you want. And yes, the Q&A is going to be anyone over a certain volume, no matter if they're embedded, if they're not. And it will include organizations that you might not want to look at. So what I tell organizations about our Q&A is now for OU Medical Center and for Edmond, it's not going to be an issue, but we have organizations that are in large specialized complex care medical centers that are an academic medical center. And they're saying, I don't want to be here. I want to be there. The answer is then compare yourself against those organizations. It's easy to do that. It's a little bit more difficult because of the embedded nature of the pediatrics within some of our adult hospitals, but we will find that compare group for you. And anything that you've seen here, you'll be able to do and drill down into. And so we're not only going to find you that compare group, get that approved by you, then we're going to go in and do some of this work to get you all the information that you need. Thankfully, there's not as much mortality, to look at, but there's complications, there's length of stay, there's utilization, there's cost and everything else. Yes. Yes.
You're not the only one. Yeah, you definitely are not the only one. So I came from a hospital. And, yeah, definitely that was their argument. I thought going into, when we were first presented with, this stuff, we got a lot of backlash, or excuse me, Vizient, we gave Vizient a lot of backlash on it. And it is something that I think all children's hospitals struggle with. And I think we as Vizient are working towards that.
Well, the fact is they're there. It's just they're more difficult to be able to tease out than the adults. And so that's what I'm saying is that when we get you this list, it'll be 60, 70 hospitals, and you'll see the names of the children's hospitals. And then you'll say, I don't want to see this one, I don't want to see this one. And then we'll be able to do that. And by the way, yesterday, Nicholas Children's from Miami just verbally agreed to come in. So they're coming in, so we do have, a number of them separated out, but like the DeVos Children's is not separated out. They're in with Butterworth. So what we'll do is we'll get you that list. We'll get you the volumes in the categories that you want. And we'll say, here's the name of that children's hospital, even though it's coming in with Butterworth. We'll get you that. Yes.
One of the things actually this is a lot of real time allows you to build on any way you want. Understand how their part of the sheet you talk about is how can I make my forecast? Maybe I can make the whole stuff. As opposed to I think what you need to understand is that this school first form changes is still on everybody five items big people out now to a level and all again I think it is actually about that it is a
So quarterly, you'll get your quote unquote report card, but to exactly to your point, but yeah, it's not as real time with our back.
when you start to see the productivity part of it involved, we start to see the platform, we start to see the yeah, I think what pure and but I think the idea that going and looking at the can after program you might also just if part of the voting is elected that long. And to be quite honest, probably say that, but yeah, changing out, we're looking at all the things. What's happening? How we do that? I think that's what I personally had an experience where after high school, sometimes you're out, you know, you're only comprehensive skills program, so it came up with there's a 14 different places that are just like that. So, you know, at some point, it starts out, but I think that justification is not important. And I really do have to use school as a driver.
You know, Rick, we may not agree on college football, but that just brought a tear of joy to my eye, that comment. There was a Tim Tebow, one of the greatest humans ever to live.
But I think the important is most of the work here. Yeah, this is rewarded the quality, have the passion for quality. So I think this message is going to all the medical staff. They are understanding complexity. It's going to be difficult to achieve what you want. So my question is how you are helping other organizations, how you can help us to take this message to our each member of.
Yeah, and we'll be talking about that in the visioning session in this afternoon. But I'll tell you one aspect, and that is Cleveland Clinic has the main hospital is broken into what they call institutes, not service lines, but many of the institutes are service lines. And the first thing they did was they built a dashboard for each institute. Then they put a physician, nurse, and administrative leader over that. And then they gave them support in terms of drilling down into the database, helping them get change to occur. They use the same metrics that we use basically in the Q&A study. Every quarter, Toby Cosgrove, who's now retired, or semi-retired, he would sit down with each of the institutes, and he would have the leaders, the physician, the nurse, and the administrator there, and they would look at the dashboard. And all Toby was looking for was an improvement. Is the line going up or is the line going down? And if there was not an improvement, he wouldn't turn to the quality department or anything else. He'd look at the physician lead, the nurse lead, and the administrator and said, what's going on? And if they said, we can't get it to the medical staff, well, you need to be able to, present this with, or maybe I'll go to the medical staff with you next time to say, this is what we're going to use to be able to improve, or maybe we need to get Vizient in here to help us with helping do that. If they said we can't get change to occur, they had lean folks that they would deploy there. And one of the things about that is that what Toby did, now the current CEO uses more carrots. Toby used more sticks. And what I mean by that is every one of those leaders had a 1-year contract. And if they afford to be the leader of that institute, if they weren't seeing improvement, Toby would shift them out and put someone else in who could get this message out to that group within the medical staff to be able to help them. So I do think it is service line by service line. It's leadership. It's working with us to be able to help you, present this information to them so that they understand it. But it's also the executives who are saying, this is what we're going to be looking at. So it's not going to be, well, I ran this report and over here and it shows us that we look good. This is what we're looking at, and so everybody's focused on the same types of things. So yeah, we are going to be working on that, and I know that that's the path that you're taking right now. Was that your question as well, Jonathan, or comment?
We have a major service line. Vizient rankings. Will police data, I'm worried that they're gonna, that they just promote or the hospital. And I'm guessing that Toby, will say that.
That's absolutely true. One of the things that Toby would do is that their pushback with Toby was, well, these aren't all patients that I think fit within cardiology. You know, some of them might fit over here, some might fit over here. These aren't our patients, he's saying. And Toby would say, those are the patients that I want you to figure out how to get improvement on. I don't care if you think they're over here, if they're over there. That's the message that he brought. If they were talking about outpatient, well, then you need to focus in on trying to get to the outpatient side and helping him do that. So he essentially didn't, any rationale that was brought back to him, he would say, I want you to look for factors. I want you to look for factors, and I want you to make changes. Look for factors, make changes, look for factors. And again, he used that kind of stick mentality where the newer one's using more carrots, like, what can we do as the executive team to help you get to this point? But you're absolutely right. There's no question anymore in those institutes about data or about groups of people, because he's kind of taken those people and brought in new people that he said, it's your data. You've got to take a look at it. Geisinger, I know that we're over time, but when they looked at their ODE ratio for oncology, it was much worse than what they had seen for the last couple of years. And so they reacted negatively. They said, it was great that you showed us some factors, but we've been told that we're awesome. Well, we come to find out they've only been seeing the patients where a hem-onc doc was a discharged physician. So whereas my report had 240 patients, their reports have 40 patients each month with zero mortality. And so now Geisinger's going through this change of saying, okay, because what's essentially happened is they missed those other 200 patients. They were masked in other places. One other thing about service lines is that we always see that everybody's like, okay, we've got them, service lines, we've got CV, we've got neuro, we've got oncology, we've got peds. There's a whole bucket of general medicine patients that you don't want to lose sight of. They're your bread and butter patients in this area. And you're probably doing it. I'm just saying that in a lot of other organizations, everybody's always focused just on those, the main five that are the breadwinners.
Some of the services actually.
Does it have vascular in it?
Some of the service line actually still have high. They've shown year-to-year improvement, which is nice to see.
It is nice to see, yes. The 3-year trend is excellent to be able to take a look at, and for those that are improving but are not yet at the average, I would say just keep on keeping it on. You will get all of these slides, and then we're also going to, start working more with the peds information. I've got Edmund's information too that I'm going to share at some point. But it's great to see all of you again. Thanks for bringing me back to Oklahoma City. Next time, though, it needs to be a little bit warmer than Chicago for me to come down here. But it's been great to have visit, and thank you. Yeah, thanks.